Hello, everyone. My name is Tina Ticinovic-Kurir. I am endocrinologist at the University Hospital Center Split, and today I'm going to introduce to neuroendocrine tumors. I will start by talking what are neuroendocrine tumors, how common are NETs, what are the symptoms of neuroendocrine tumors, classification of NETs, how are they diagnosed and staged, and how are they treated. Neuroendocrine neoplasms are a group of very heterogeneous tumors with neuroendocrine differentiation, and they can arise from any organ because neuroendocrine cells are located all over the body. They can secrete peptide hormones and present with a broad spectrum of symptoms based on the hormones secreted. Some people use term carcinoid tumor when they want to describe this type of tumors. This term was coined in 1907 by German pathologists who first observed a group of slow-growing tumors, and he named carcinoma-like, benign carcinomas, or carcinoid. Today we know that the most common neuroendocrine tumors are not benign. They have malignant potential, and they can spread to other organs, particularly into liver. The incidence of neuroendocrine tumors is low, but on the rise. As you can see on the left-hand side, the incidence of neuroendocrine tumors are increased over the last few decades compared to all malignant neoplasms. The highest incidence has lung neuroendocrine tumors, followed by colon, small intestine, and pancreas neuroendocrine tumors. They account for 2% of all malignancies in the United States. And I would like to point out that gastroenteropancreatic NETs are the second most prevalent neoplasma of gastrointestinal origin after colorectal cancer. The prevalence is also high due to better diagnostic, better treatment, and generally people with neuroendocrine tumors live longer nowadays. Neuroendocrine tumors can originate from any site. Traditionally, we classify based on embryological development, and we have NETs from foregut, midgut, hindgut. As you can see, the most common primary site is small intestine, 55%. Then lung neuroendocrine tumors, 40 to 45%, and then pancreas. One way we can classify neuroendocrine tumor is by whether hormone or not cause symptoms from hormone excess, and we divide into functional versus non-functional neuroendocrine tumors. The typical clinical presentation is carcinoid syndrome. 10% of small intestine neuroendocrine tumor present carcinoid syndrome. 40% pancreatic neuroendocrine tumors are functional, and they include insulinoma, gastrinoma, glucagonoma, and lipoma. And definitely symptoms defined by hormones secreted. In this slide, you can see where functional neuroendocrine tumors are located in the human body: thyroid, lung, pancreas, adrenal, small intestines. But I would like to point the minority of neuroendocrine tumors present carcinoid syndrome, which is generally associated with metastatic disease. The clinical manifestations are caused by serotonin, which is metabolized by liver into 5-HIAA. Carcinoid syndrome depends on volume of disease and location. Typical symptoms are flushing, diarrhea, dyspnea, and long-term complication of serotonin overproduction are carcinoid heart disease, mesenteric fibrosis, neuropsychological disorders, and patients with carcinoid syndrome have worse prognosis compared to patients without serotonin overproduction. Lung neuroendocrine tumors can also present syndromes, but syndrome is rare. Only 6% of cases present Cushing syndrome, carcinoid syndrome, and acromegaly. In this slide, you can see classical features associated with pancreatic neuroendocrine tumors. We have to recognize syndrome within gastrinoma, glucagonoma, insulinoma, somatostatinoma, or lipoma, because the treatment and diagnostic procedure are different for those patients. Nearly 80% of well-differentiated neuroendocrine tumors express the somatostatin receptors on the cell membrane. It's very useful for diagnostic procedure and for treatment with PRR, peptide radionucleic receptor agonist. When we are talking about diagnostic workup, we should include anatomic and functional radiographic modalities. For anatomic imaging and staging, the options are CT scan and MRI. For functional imaging, in well-differentiated neuroendocrine tumors, the options are octreotide scan, DOTA-TATE PET, and DOTA-TOC PET with gallium-68, and DOTA-TATE with Cooper-64, and regular FDH PET with PET scan. What is the difference between PET scan with FDH versus gallium-68 DOTA-TATE? Gallium-68 DOTA-TATE is better option for grade 1 neuroendocrine tumor with more somatostatin receptor expression, but for patient with neuroendocrine carcinoma grade 3, the better option is FDH regular PET scan. In this slide, you can see CT and MRI patient with metastatic neuroendocrine, liver metastatic neuroendocrine tumors. PET scan with gallium-68 DOTA-TATE for patient with well-differentiated neuroendocrine tumor, and PET scan with FDH for poorly differentiated neuroendocrine carcinoma. When we are talking about staging, we divide into anatomic versus clinical stage. Anatomic stage include 4 stages, depends on the spread of tumors, extension of tumor. Stage 1 means localized, stage 2 localized but more advanced, stage 3 spread but more advanced, and stage 4 spread to distant sites such as liver, bone. Clinical stage include localized tumor, liver-limited metastasis, and widely metastatic disease. When we are talking about laboratory studies, there are no perfect tumor marker. And I would like to point out screening for hormone secretion in asymptomatic individual is not routinely recommended. American Joint Committee on Cancer advocates against the use of serum chromogranin A for the diagnostic and monitoring of gastroenteropancreatic neuroendocrine tumors. But in patients with well-differentiated neuroendocrine tumors, functional neuroendocrine tumor, we should be evaluated on the basis of presenting symptoms such as 5-HIA acid. And this slide shows specific biochemical markers for different neuroendocrine tumors. It's a little confused about terminology. Some people use neuroendocrine neoplasm, neuroendocrine tumor, or neuroendocrine carcinoma. The recommendation is to use term neuroendocrine neoplasma as umbrella to cover both neuroendocrine tumor and neuroendocrine carcinoma. What is difference between neuroendocrine tumor versus neuroendocrine carcinoma? Generally, neuroendocrine tumor means well-differentiated tumor, neuroendocrine carcinoma for poorly differentiated neuroendocrine neoplasms. We can classify a tumor based on two components into three grades, grade 1, grade 2, and grade 3, based on Ki-67 and mitotic rate. Grade 3 can be poorly differentiated neuroendocrine carcinoma if Ki-67 more than 20% and mitotic rate more than 20 mitosis per 2 millimeter square. The 2022 World Health Organization updated epithelial neuroendocrine neoplasma classification and staging, and for the first time included endocrine and non-endocrine neoplasms for group gastrointestinal tract, upper airway, thymus and lung neoplasma, and fourth group thyroid neoplasma. I would like to point the experience pathologist is crucial for classification neuroendocrine neoplasms. You can see well-differentiated and poorly differentiated neuroendocrine neoplasms. Poorly differentiated neuroendocrine carcinoma can be large cell or small cell neuroendocrine carcinoma. Grade Ki-67 index for classification into grade 1, grade 2, and grade 3. I want to talk a little about treatment landscape in neuroendocrine tumors. We didn't have many treatment options before 2000. But it has been the explosion of new treatment over the last 2 decades. I would like to point that the management of patients with neuroendocrine tumors have to be personalized from patient to patient. We have determined tumor characteristic and patient characteristic, age, comorbidity to decide what is the best treatment option for every patient. We have to assess extent of disease, pace of growth, primary site, grade, differentiation, hormone status, somatostatin receptor expression, and then to decide what is the treatment. We have many treatments for tumor and hormonal control in advanced disease. We will talk later in the detail. Also about systemic therapy. Definitely treatment for various neuroendocrine tumors is complex, and it's important to multidisciplinary team and approach for create the best treatment for every patient. I would like to conclude neuroendocrine tumor have a heterogeneous biology that impact prognosis and treatment. NETs can secrete hormones resulting in clinical syndromes. Routine assessment of non-specific biomarkers is not recommended, and tailoring treatment for every patient requires a careful balance of patient and treatment characteristics. Every patient with neuroendocrine tumor needs a multidisciplinary team and multidisciplinary approach, which include many different specialized endocrinology, nuclear medicine, to provide the best treatment for improved prognosis and quality of life our patient with neuroendocrine tumors. Tomorrow is World Neuroendocrine Cancer Day on 10th of November. Is very important day to increase the awareness of neuroendocrine tumors and to provide the support to the NET community for improved diagnostic, treatments, care of patients with neuroendocrine neoplasms. Thank you for your attention and thank you for joining us today. Thank you.